This week on the BackTable Podcast.
If you think about it, it's kind of fascinating that for Fournier's gangrene, there's now a new surgical technique on how to take care of it. We don't see that kind of change in technique that much for other urologic surgeries, but I think either you have to be aware of that skin spare and know how to do it, or that you're absolutely right. It would be so tricky to know the balance because that disease can spread so quickly, make someone so sick to the point they could die from it within hours, but then the transfer itself takes usually at least 4 hours, I always say, if it's quick.
This is George Koch from The Ohio State University, and I'm really excited to introduce Dr. Judith Hagedorn this evening to talk about a topic that's near and dear to our hearts and maybe a little bit further away from most others, Fournier's gangrene. Dr. Hagedorn is an associate professor of urology at the University of Washington in Seattle, Washington, as well as the residency program director at UW. She earned her bachelor's degree from Rice University and then a master's degree at Johns Hopkins Bloomberg School of Health before earning her medical degree from Stanford School of Medicine. She stayed on at Stanford for residency before a fellowship in urologic trauma and reconstruction at the University of Washington, where she stayed on as faculty and is now program director there. Thank you so much for being here today, Dr. Hagedorn.
Oh, thanks so much for having me, Dr. Koch.
Absolutely, absolutely. There are not many people who feel about Fournier's gangrene the way that I do, so I knew that you were the right person for the episode.
I'm honored.
So our episode is about Fournier's gangrene, which is something that I think most urologists have seen in some capacity, even though it's considered pretty rare. But could you start by telling us a little bit about your experience with Fournier's?
Yeah. So first of all, I'm excited to be here to talk about that topic with you. And you're absolutely right. It's a rare disease, which working at Harborview, for us, it's quite common there. That's where you did your fellowship, and we debrided a lot of Fourniers and reconstructed even more. But I saw my first case in residency, and I only saw one Fournier's case. It was a scrotal necrotizing skin infection that we took and debrided. And I remember, the teaching was always to cut more and more and more until you found bleeding edges of the skin. And that's how that was my first case. And then I went to fellowship, and there we are, now I think the center of excellence for the Pacific Northwest.
You mentioned a little bit about the way that you were originally taught. You kind of alluded to it. Has your management with Fournier's changed over time from that first instance as a resident to now, leading a center of excellence?
In the past, I thought of that the disease process was kind of almost like a tip of an iceberg, where you could kind of see a necrotic spot, and then during the debridement at the skin level was huge. You cut out the necrosis, but even more skin. Whatever skin was overlying dead tissue, you would cut it away. And then I think with having our plastic surgeons, Dr. Carrie Keyes published on that, talking about skin sparing for better reconstructive options, we then kind of leaned toward that. But you really put that into action when you were at Harborview during our fellowship, where you really went in for every single debridement that year. You showed us that it's possible to debride without having to cut away all the skin, and that can then save the patient from needing a skin graft and having this large open wound. And many times we didn't need a skin graft anymore because of that skin spare.
Yeah. And you mentioned skin grafting, which I think I wouldn't be surprised if a lot of people were surprised about the idea of skin grafting, a patient who's a Fournier's patient. I was at the American College of Surgeons this past weekend and talking to some people about it, and they were shocked. They were like, "Oh, you must mean skin grafting and follow up, or skin grafting, after months and months." If you could talk a little bit about what you're doing at Harborview to reconstruct these patients, whether they're grafts or skin flaps or skin closures. Is this something that you're discharging them with wound care and then closing them as an outpatient, or are you doing it more in the inpatient setting before they get discharged?
when they are acutely ill still, I think what we do extremely well is doing several looks. The first debridement, and then within 24 hours, a second look, and maybe a third or fourth look, and making sure that all the, deceased tissue has been excised and the patient's getting better from that standpoint. And then we don't discharge them. I actually had not so good experiences with discharging the patient with either a wound vac or dressing changes because they come back with wounds that are not ready for closure or grafting because the granulation tissue forms and they're just not as pliable anymore. And then you have to debride even more and then the wound care before they are then ready to graft. So I think it's for us at Harborview, we usually keep the patients in-house. And once they do better from a medical standpoint, from an infectious standpoint, we then close them or graft them.
Yeah. I don't know that you and I have ever talked about those before. The patients who you had tried to send home with wound care, it was before my time at Harborview. Did you end up having to readmit those patients for, in-depth or operative wound care again before trying to close them?
Yeah, where they come into clinic and you want to, the extended length of stay for patients, it's hard because they are in an environment that is, difficult to stay in for that long, and they want to go home and be with their families or in their own environment. So you try to discharge them, but that really didn't work really well because they come back to your clinic and you see that soupy wound that still has this probably Pseudomonas infection potentially or smelly, and then you have to really take them again to debride, and you're starting almost back at where you discharged them. At zero, exactly.
You're kind of alluding to it. Harborview, your trauma center in Seattle, gets a lot of these patients. And I know that there's some literature, and some of it's out of Harborview, about, high volume centers versus low volume centers. I think we're dancing around a little bit about, talking about what we can do at Harborview versus what other places may typically do. But can you talk about a little bit about the value of a high volume center? We joke about Harborview being a center of excellence, but what's that mean? What does that provide the patient, do you think?
I think that initially, when the patient presents, the providers in the ER have a high suspicion for Fournier's, which you need to have to really diagnose it well. Yeah. It can be unrecognized. I think I've heard you talk about that prodrome before, where I think there's also some literature from Brad Erickson on that, where they found that there's a prodromal phase of Fournier's where the patient may have just cellulitis for a week and then it kind of becomes Fournier's gangrene. But our providers in the ER even have a high suspicion because we see so many patients who come in or are transferred for rule out Fournier's gangrene. And once it's diagnosed, then start antibiotics immediately, involve the correct teams, which is usually general surgery plus us in urology, maybe OB-GYN if there's a female Fournier's gangrene patient, sometimes vascular or something, other services have to be included in that initial consult. And then we go to the OR super quickly. And I think we have the advantage of being a trauma center where patients get crashed to the OR frequently. And so we can crash Fournier's gangrene patients to the OR super quickly and debride their wounds, and everyone is on the same page on that. And then after that, the wound care. I think that the nursing staff on the floor does so well with wound care and dressing changes and making sure the patient is as comfortable as they can be with medications, and they are really taking good care of them. And sometimes vacking, we have vacked quite the complex wounds.
Yeah, absolutely.
Together.
I wish we could put some of those photos in with the episode, but I'm sure they won't be allowed. But this is one thing that I have the hardest time convincing people of with the disease process. But if we're saying that, we do a great job of recognition, we do a great job of initial debridement, wound care, closure, all at a place that sees a lot of these and gets a lot of these as transfers. I think the next big question is, should all Fourniers be getting sent to a center of excellence or a tertiary center where they do a lot of them? Should these be taken care of in the community?
What a good question. And I do think we see quite a few transfers now coming to us for even the initial debridement, but we do know from literature that the time to initial debridement can have impact on the outcome, and if you don't debride, there might even be mortality, a higher mortality rate. So, you have to balance that. And I think that the Fournier's initial debridement, even if you can't reconstruct, but every urologist should have that in their armamentarium to be able to debride a Fournier's gangrene.
Yeah, I think balance is the word, because there are some times where I would argue, I can think of patients that you and I have had that, and we talked about skin sparing debridement versus radical debridement. Some of that is that the dogma is radical debridement, right? And I think that you're never going to get, as a urologist who's doing 2 or 3 Fourniers a year, you're never going to have a patient who has a bad outcome where you get, in trouble, medical legally or with your hospital system or whatever, if you do the dogma, the standard of care. Trying to convince people to do skin sparing, I think, is easy in an academic center where they can, where I say, call me if you're on call and you want, help with one of these, or if you're close by, transfer them to me. I think it's harder with a urologist that is just going to see 1 or 2 Fourniers a year, just wants to make sure all of the infection is absolutely taken care of. And in some of those cases, I would argue transfer before debridement might be better for the patient if they're otherwise stable, but I don't know how to quantify that and how to pick the right ones and how to collaborate yet with my outside urology colleagues to figure out who needs to be debrided and who needs to be transferred. I grapple with that.
I know you yourself on a mission to spread the skin sparing. You have a video on it, and I think that's really important to kind of spread that new surgical technique, which, if you think about it, is kind of fascinating that for Fournier's gangrene, there's now a new surgical technique on how to take care of it. We don't see that kind of change in technique that much for other urologic surgeries, but, I think either you have to be aware of that skin spare and know how to do it, or that you're absolutely right. It would be so tricky to know the balance because that disease can spread so quickly, make someone so sick to the point they could die from it within hours. But then the transfer itself takes usually at least 4 hours, I always say, if it's quick.
Yeah. If it's quick, yeah.
If it's quick, so...
Yeah, I'm without like talking too much about a specific patient. For those of you that don't know, your husband does some like primary care and emergency medicine out kind of in rural parts of Washington. And I remember, and I think you probably remember, a patient that he called us about and got transferred to us with like a big necrotic black spot on his skin because they didn't have anyone who could do it. And he got to us and he was discharged on post-op day 5 with just a single closed, incision. I don't know if you remember the specific patient that I'm talking about, but...
I do. I remember getting that call from my husband. He said, I cannot find anyone around to take that patient. I was like, we immediately send him here.
Yeah, and he, he got what you're describing, right? He was into Harborview within a few hours. He was in the operating room, within, less than an hour after that, and got a skin sparing debridement. We took him back one more time and then closed him. But I think about him a lot when I think about, should this patient get debrided on the outside where I think the risk of a radical debridement is high, or should this patient, get sent to me first? And, like, I guess I'm being a broken record here, but it's trying to know that balance is tricky, and I don't know what it is yet.
And, we had my husband had the luxury of knowing that you and I were at Harborview waiting for Fournier's gangrene to come in.
Exactly.
But can you imagine if you have another ER doc who needs to call around, and they would have maybe a general surgeon on call, and that calling around different hospitals, I think, which has become more common now with staffing issues where they have trouble getting the patient anywhere. And so then the general surgeon on the ground locally should really debride, because if it takes 6 to 8 hours to transfer, to find a bed for that patient, then it's better to do the first debridement.
Yeah. No, that is definitely true. And I think that, Harborview was such a special situation. Dr. Wessel sometimes will talk about academic centers being kind of the test kitchens for kind of the newest and innovative, techniques. And I just wish I could figure out how to make it, more reproducible,
Yeah. It's watching your skin sparing videos,
Yeah. I need to keep putting them out there.
Yeah.
So if we're saying that, transfer to a high volume center at some point is the way to go, then are we saying that probably the safest thing to do is first debridement in an outside hospital and then transfer to a high volume center after that?
I gotten those calls also where the first debridement has been done, patient is now more or less stable, or at least on broad spectrum antibiotics, and may or may not be in the ICU for resuscitation, but they, if you do the skin spare, that closure, I could imagine also being done locally. And you and I have accepted patients before where, not a lot of skin is missing. And what we then do is maybe have the patient come, we assess the wound, we get, a few more days of wound care in, and then we primarily close it. And that primary closure is not so difficult. I mean, it's, little arts and crafts of getting the different tissue layers together and closing, like we always say, in layers to make sure this wound stays together, ideally with a drain, so the fluid doesn't accumulate. And then you can send the patient out really the next day. Some of those wounds break down, and that's just something you would need to be aware of or expect almost. But others just close up really nicely. And what we do usually, we use some Maxon, I think, on the skin, just a little bit something with more lasting than Vicryl to just keep it together. But those skin closures are also not so tricky, especially if the skin is there. But I think at the other hospitals, if they are not as experienced, the wound care might not be adequate. So the wound may never look healthy enough to be closed if you don't have those dressing changes or vacs that you can put on. And we do such a good job of that at Harborview. So usually I accept those patients all, to make sure they have a good hospital stay and then get a closure and go back to their local
situation.
Go back home after, situation after.
You bring up an interesting point because, the studies in Fournier's are kind of few and far between, except, Brad Erickson's done some really great work with administrative data where you can see, these small, rare conditions in like a big administrative data set. But I do think that kind of the granular on the ground research that you can do with some other disease states, it's tough to do with Fournier's just because it is pretty rare center for center. The data would say that wound vacs are not the thing to do, that they don't result in better outcomes. Now, I'm a huge believer in wound vacs, as I know are you, but could you talk a little bit about kind of wound vacking Fournier's? Because, at first blush, people are going to listen to this episode and be like, oh, if you cover the wound, we can't serially assess it and it could get worse under the vac. And so talk a little bit about that if you could.
The vac is like something you should consider, not initially. The initial debridement, you'll have a field that's full of pus and dead tissue, and you need to look at it again. And I think the first couple looks, you don't consider a vac. But thereafter, you need to then think about, is it possible to place one? And I think we both have surprised each other with our nurse practitioner, Erika Orban, who has a wound ostomy background, and she has really taught us how to vac all kinds of wounds in the genital area, and no matter how deep they are. And so I think we can vac pretty much all wounds in that area. You can also, put the vac around the penis if there's shaft skin missing. That's okay. Some people turn down the vacuum, the negative pressure a little bit, but you shouldn't consider it in a florally infected wound. I think once there's still soupy dishwasher fluid coming out, sometimes we see that where like a pus pocket wasn't initially detected and then you go in and have another pus pocket draining. I wouldn't put a vac on that necessarily, even though it might clean it up.
Yeah.
You know,
Yeah.
it sucks out all the dirty fluid. So you could even make an argument to maybe place it even a little earlier than we do currently, but usually we wait until the wound looks at least not grossly infected, and then we help it with kind of shrinking it down. And I think that's when you take off those vacs and then there's like healthy red bleeding tissue and you're like, this is wonderful. Whereas,
this is good stuff.
you know, it is good stuff. Where, you know, if you change those gauzes, there's probably this like whitish, thick granulation tissue that needs to be carotid or debrided again before you then can close.
Mm-hmm. Yeah, I definitely think, and I think in kind of the era of skin sparing, I think it's nice too, because sometimes, you know, you raise these big wide tissue flaps, and I just always worry about the gauze like getting packed deeply enough. You know, our poor like junior resident is doing this at 4:35 a.m. in the morning, and like, are they getting deep enough under these big flaps of tissue? You know, and you know, a lot of our Fournier's guys are not small people. You know, they like have a lot of places to pack.
Yeah, you could lose something in there.
Yeah, absolutely.
You know, the edema that develops is usually also an enemy of closure, because even though the first debridement, you're like, okay, this comes together well, we can close it eventually, but then everything else around that wound gets edematous and full of fluid, and I think the vac helps with shrinking that down.
Yeah, absolutely. And I think it you know, if you've got the vac under those, you know, kind of flaps of tissue, I think it kind of keeps them mobile. You know, it allows the base of the wound to retract, but some of the more floppy stuff, it doesn't allow it to like kind of get stuck down, is my thought. I don't know.
Yeah. And I definitely think that when I first started in my training, we didn't do a lot of vacs. And then I think Dr. Skokan, my colleague at UW, he was always a proponent in vacking. And then, you know, with the skin sparing, I think we vac even more. So, yeah, I think it has definitely an advantage, even though maybe in the literature it's not obvious.
Yeah, I think it's one of those things that I hope that someday we can have some literature to support it. But I think it might be, we're in kind of a pre-data space with wound vacs. You know, I don't know that the studies yet have really been able to kind of capture the patient population.
Yeah. And some other ancillary things that I think you have been using is the, I don't know if you're just using that because it's kind of fun, is that a pressure irrigation and some chlorhexidine potentially to kill bacteria, which kind of makes sense, but we also don't have any data on that.
Yeah, the one thing I really like, Scott Breckenridge at Harborview used to say that any closure should really be a re-debridement. So I really treat, you know, when I close these wounds, I treat them like a re-debridement, right? I make sure to excise any, you know, excess, non-viable, not useful tissue, you know, some of that fat, even if it looks healthy, if it's in the way of getting my skin edges together, I excise a lot of stuff. And then you're right, I love the pressure irrigation, wash the wound really well. You know, I think people are afraid or hear like rumors about the pressure irrigation like pushing bacteria deeper. But I think in a wound that's had good wound care and it's clean, the pressure irrigation is really nice with a little bit of chlorhexidine soap. I think that it kind of sets the wound up nicely to not get reinfected.
Yeah. And you're right. I think that when you decide to close, there's quite a bit of debridement still happening during that surgery. Many times the testicles are, and we should talk about the testicles, George.
Yes.
Don't forget about the testicles.
I will not forget about the testicles.
We should, you know, you have to free them up because they can get quite stuck. And one of the hemiscrotums might not even budge at all and you feel like you can't close, but then you really have to free up the testicle and free up the skin to be able to make it mobile again.
Yeah. Let's talk about the testicles a little bit. You bring up an excellent point. I can't remember which AUA it was, but a couple of years ago at AUA, there was a presentation where I think it was at West Virginia. They were, as a group, I think their surgery services were doing some orchiectomies because the testicles kind of looked so bad visually during their debridements. And this group of, I think it was the urologists or the urology department of West Virginia, they were arguing that, these testicles should be saved. So they took, however many years worth of orchiectomies and looked back, and all the testicles were read as like viable tissue by the pathology department. And I remember Drew Peterson got up and he talked about like how brave it was to present this literature, that because, we're always taught that the testicles are in a separate compartment. They're viable in Fournier's even when all the skin of the scrotum is dead. And how brave it was to, present this literature because someone had done these orchiectomies and, they were just doing their best to try to kind of make the case to save the testicles. And I love that project. We're talking a little bit about it. We save the testicles typically in Fournier's because they're in that separate, anatomic compartment. Their blood supply comes from somewhere different. Even if the entire scrotum is taken off, the testicles survive. What do you do with those testicles once they're hanging in the breeze? You taught me this actually. I'll never forget the first time I didn't do what I think you're about to recommend, and it was real pain in the butt to get it back where it belonged. So talk to me. You see a patient from an outside hospital. They've come in. They're debrided. Their scrotum's gone. They've got 2 testicles. They're wrapped in zero form. How do you handle them?
It depends a little bit about how far along they are in their debridement. So I think you have the luxury of looking 24 hours, 48 hours, but then, and that happens sometimes when they are really sick in the ICU and they can't come back down because they have maybe multi-organ failure and you have this open wound that is being cared for, and you are not looking, or they have potentially such bad Fournier's that it's also necrotizing soft tissue infection that goes down the thigh or up the abdomen. And the team say not ready for closure because of how sick the patient is. And that's when those testicles can retract up. Mm-hmm. And that's when I think you are alluding to where those testicles, they retract and they are incredibly difficult to bring down, even if you mobilize the entire cord. It just doesn't have that stretch anymore. And so it's really hard to bring them below the penis in an anatomical location. So what you usually should do within, I would say, the first week or so is pexy them together with a few layers of suture to bring them below the penis and have them be one unit. And then I guess you could still, remove those stitches and put them in thigh pouches, but at least they're long enough. The cords are long enough and mobile enough. Or you can then graft if there's no scrotal skin left, or then if there's scrotal skin left, you close that over them. But that's really important to bring them down.
Yeah, no, I remember taking care of one of these guys and having trouble, bringing it down. And you were like, you lost this battle a couple of weeks ago when you didn't pexy them together. And now I'll pexy them together and I try to get them like to the perineal body as well. Even if you have to, every time you take them back for, a debridement, cut the stitches, clean up the wound, and then put them back, I think it's like hugely beneficial for being able to put them, where they belong in the end.
Yeah, great. What about the thigh pouches, huh?
Yeah. So that's another interesting point. I know that it's controversial as to, do we put this testicle on a thigh pouch or not, versus do we, skin graft the scrotum. I've seen people advocate for orchiectomy in that case when you're leaving the other side. That's not my practice, but I've certainly heard of people doing it because it can be tough, especially in these guys where you're talking about where you may not have thigh skin or you may not have skin on the mons. So I think I would advocate for always saving the testicles whenever possible. The West Virginia paper was all that I needed to kind of confirm what the dogma is. And if that means putting it in the thigh pouch, then you put it in the thigh pouch. But I think the real point you bring up is not to thigh pouch or not to thigh pouch. It's to understand what the patient's goals are and what's realistic for them. So maybe talk about that a little bit as far as closure techniques and strategies and things like that.
I think that's so important. It's basically the patient's wishes. And I've had some that say, I want to get out of here as fast as possible. And that they would need some more bed rest if you do skin grafting. They would have probably an open weeping wound for a while until all the skin graft has taken, and there's all these crevices that you can't really skin graft well. So they have like these probably wounds that last for another few months. Or they might want to just have a primary closure, and that might not be possible if they have their testicles, if they want them covered in their skin. So you would have to put them in a thigh. Or rarely, very rarely, but I've done this before too, is if the patient doesn't have thigh skin and they want to really leave, they have one hemiscrotum, that they are okay with an orchiectomy on the side that cannot be covered other than with a skin graft. So they say, you can take the testicle and the other one will be covered by my native skin, and we can just move on with reconstruction rather than having the skin grafting over all of the testicle. So I think the thigh pouch is we use it once in a while for sure.
Yeah. I mean, I think it certainly has a role. My argument is always I'll offer the patient kind of everything I think I can, but I try to be pretty realistic with them with exactly what you said. Like, we can skin graft this, but you're going to be probably in the hospital for, at least days more, if not a week more, if we, do some of these complex closures and some of these grafting procedures. I don't know that it's always realistic for folks. I mean, these are guys who came in with Fournier's gangrene. A lot of them are uncontrolled diabetics. A lot of them, I worry about being able to handle their own wound care other than a closed suture line. And I think that when you really sit down and talk to a lot of these Fournier's patients, a lot of them are totally fine with a thigh pouch if it means getting out of the hospital faster. They've already been there for days to weeks. They're tired of, dressing changes or even wound vac changes or going to sleep in the operating room. And I think sometimes the residents are often surprised, like how many people are so willing to be like, thigh pouch would be great. Just get me out of here, And you can always bring them back electively for reconstruction afterwards, is my argument to them. And I've only ever had one person who came back. He said when he wore tight jeans, it hurt his testicles and he wanted a reconstruction. He's the only one. Yeah,
it's usually because of some discomfort that they may have, but very few have. To your point about saving testicles, you did the study at Harborview, which is just now getting written up on the endocrine function of the testicles during Fournier's, and the hormones plummeted during the acute disease. But then you showed no matter if thigh pouch or reconstruction, the endocrine function came right back.
Yeah, it's unpublished data. It's small numbers, but we had, I think, 12 or 15 patients who, you're right, their testosterone went to undetectable during the acute phase. And when we started seeing those results, we started to think like, did this overwhelming infection kill the testis anyway? Like, are we accidentally saving these things? And even if the tissue's viable, they don't have function. But then in follow-up, their function did come back. It was slow. And again, unpublished data alert in a very small group of patients, but we saw that the testicular function came back at least to like physiologic levels, even if they were a little hypogonadal.
Yeah, and it supports the argument of saving them. I do think there are some cases where the actual infections potentially started in the testicle. It was probably one of those necrotizing chorchitis that they then developed Fournier's from it. I've seen that before, where you open the skin and the testicles mush and completely not viable anymore. And I've seen them fall off the cord without having to cut the cord or tie the cord off, because of thrombosis of those vessels. But that's the rare, I think, case.
Yeah, the exception.
Yeah, the exception.
That is something that I hope I don't get scooped down by someone who's faster at research than I am, but kind of the idea of like inside out Fournier's versus outside in, like the patients, at least in my experience, the patients who develop Fournier's from urethral trauma, from like colorectal GI trauma of some sort, and ones that have like orchitis, at least necrotizing orchitis, like those ones I just don't think do nearly as well as the people who have external skin injuries that, kind of go outside in versus inside out.
It might be that it has time to fester, to come to the surface or something like that. I don't know.
I don't have any data to support it other than a gut feeling, but there are a couple groups that I'm working with that are starting to try to look at that question of outside in versus inside out etiology, because I think it's just a fascinating question.
I've seen The inside out makes me think of those cases where the testicle is dead, or you find a completely necrosed urethra, or potentially even penis.
Yeah.
And we've seen that together where the penis is just necrotic underneath everything. The corpora.
It's those ones where, the classic teaching is that it's a fasciitis, right? And it doesn't go deep to those deeper structures. But if it starts in those deeper structures and then works its way out, then kind of all bets are off. And you really have to be thoughtful about the debridement, thoughtful about the reconstruction, careful while you're debriding, because you can come across things where normally, the tissue just kind of peels away at the fascial level. But, those inside out ones can be tricky.
Yeah, that brings me to the thought of, when do you use an SP tube? For those deep infections that have a necrotic urethra, that would be definitely a case where you want to put a SP tube in. But how often do you use the SP tubes? I don't think we do very often if the urethra is fine.
Yeah, I almost never. Only urethral necrosis, or I've used SP tubes when we've had like really bad stricture disease, where even if the Fourniers didn't come from a stricture and then a fistula, even if they're separate problems, they, I know that the catheter is going to come out and they're going to restricture. I've used SPs in those cases, and then I've certainly managed SP tubes when they get put in at the outside before they come to us. But it's pretty uncommon that you need it if you can get a catheter in the urethra, whether the penis has skin on it or not. Like most urethras can take the catheter just fine.
Yeah. And same for the colostomies. We've seen that our general surgeons or trauma surgeons at Harborview, they rarely divert with a colostomy. It's a big surgery for a sick patient, and then they have to be diverted again if they survive. But even if the disease goes around the anus, usually the fecal management device or something like that can help divert the poop from the wound, or the stool, I should say, from the wound. Yeah, so I think this SP tubes and colostomies are kind of still in the books, but very rarely used now.
I have seen some remarkable like anal islands that still we are able to end up closing primarily, I think that the fecal management systems do usually a good enough job. Now, realistically, like they leak, they blow out. It's not perfect, but I do think that if you can avoid a colostomy in most folks, it ends up being beneficial for them, because that I think we can talk a little bit more about, because at least it was presented at a meeting a couple of years ago. But Omran Awada, one of our medical students at the University of Washington, presented, what was the number? I thought it was like 10% of patients get undiverted.
Yeah,
in the long run. Yeah,
so you commit them to a permanent colostomy.
Exactly. Even if it's just for, if it's for like perianal disease and there's nothing to sew to, then there's nothing to sew to, right? But if you're just doing it for wound care, I think you're committing someone to a colostomy just for wound care. I think it's a tough sell.
Yeah, absolutely.
We're hitting all the highlights. This is great. What's next in Fournier's? We've talked about kind of the skin sparing that we're trying to implement. And I really think that is we made a video and maybe put a name on it. But I think that is a movement that especially at the University of Washington and even in the general surgery literature, I think that's kind of happening already. When our, how-to paper came out last year, 2 years ago, there was already a meta-analysis on skin sparing. So like people are doing it. And I think it's newer, but it's still, or I'm hoping it's more contemporary. But what do you think the future is for Fournier's?
Just to describe it, you basically cut away the obviously necrotic tissue, which is black. And then the rest of the skin you spare, and you may even have to correct the underside of the skin, where it's gray. Mm-hmm. But since we take those patients back anyway for a second look, third look, you can assess its skin again in those other looks, and you drain the pus and the deep structures. Anything that's necrotic, you cut out.
Yeah.
But the rest you leave.
Yeah, that was I never worked with him. Ron Mayer, I think his name was, the
chief of
of trauma at Harborview, I think. But I've heard stories about him used to, he would look at a tissue and he'd say like, yeah, give it a shot. Yeah, give it a shot. You cut out only the stuff that is frankly necrotic. And my argument was always, ischemic skin does not cause, life-threatening sepsis. Necrotic skin causes life-threatening sepsis. And if you can take away all the necrotic stuff and you accidentally devitalize some things, like take it off during the redebridement, they'll still recover from a systems, from an overall standpoint. And then, you can hopefully get a second look when they've got, a little more, they're off pressors and they're a little more stable.
You asked me what's next in Fournier's. I think, maybe spreading the news about the skin spare some more. And I like us thinking about the transfer, whether or not that should go to Center of Excellence immediately or should it be debrided. We don't know, if that makes a difference in outcome, but it may, the delay of debridement, we know makes a difference. There has been, changes in antibiotic regimen. We now use linezolid and zosyn instead of the triple antibiotics that were used prior. And linezolid and zosyn cover MRSA and most of the bacteria that you find in Fournier. So that has been a change.
That's a big one.
And then, I think you and I tried to do that, but didn't have granular data enough is maybe to test another one of those scores, the Fournier's Gangrene Severity Index or the Lindrich score with some newer data. That would be kind of neat to be able to predict a little better, the prognosis, and that would be nice to do in a more recent cohort, I think.
Yeah, the Fournier's Gangrene Severity Index, we looked at that one specifically, and I went back and looked, it's like the reference by which people who are doing Fournier's research comment on or stratify like severity. I went back and looked at that paper, and I want to say it was less than 20 patients. It surprised the heck out of me. I would have thought that it was some huge number.
Yeah, I think that we can do, and it's been a while since that got published.
Yeah.
So I think that would be good to kind of have a more recent cohort, and then maybe a Center of Excellence to look at it to see what the outcomes are. It
would be great to see in a big number. I've certainly seen papers over the last couple of years, and Niels Johnson presented one. It wasn't his work, but he presented when he was talking about scoring at the American College of Surgeons last year, and he had an interesting paper about like all of the different scores that you could run with Fournier's, and I'm blanking a little bit about what the result was of that, but they all did well. They all did pretty well. I can't remember if one stood out.
Yeah, I think they're very similar.
Okay. So one thing that I do think I would love to see coming down the pike is, with the advancement and development of these super nuanced medical record systems we have now, I would love and Niels and I talked about this when I was at Vanderbilt and, never moved forward with it, but I would love some sort of tool to kind of build on Brad Erickson's work about prodromal Fourniers. And I'd love to see something that kind of like flagged in the medical record, like this guy, has scrotal cellulitis, but he's high risk for Fourniers, or this person has, urinary retention, but they're actually high risk for Fourniers, like they should be evaluated, or vice versa. This person's super low risk for Fourniers. I would love to see us be able to better identify people who present in that prodromal state.
I don't even know when he examined the prodromal state, it must have looked at diabetes and how their blood sugars were controlled, since we sometimes see patients come in with incredibly poorly controlled blood sugars or maybe even newly diagnosed diabetes, and that diagnosis comes with a presentation with Fournier's gangrene where they...
I can't remember if he looked at it directly because he was using Market Scan, and I don't know how granular that data got, but they were symptomatically similar diagnoses was the term that he used, and it was like groin pain and scrotal cellulitis and urinary complaints, and he looked at how many people had those, what we would consider not like mild, not serious diagnoses. And then they looked back, or they looked forward to see within a certain amount of time, how many of them actually presented with Fournier's. And, he found that, and I'm going off the top of my head a little bit, but he found that there was a pretty noticeable inflection point at like the 21-day mark. And within 21 days, I think a huge number of patients, or a huge percentage of patients, much bigger than you'd think, had actually presented multiple times to an emergency department with complaints of these symptomatically similar diagnoses. And then they were diagnosed with Fournier's. So, his argument was, is there something happening within this window that we could catch these patients and potentially, treat them before they became a Fournier's? You see these people who come in and they've got this life-threatening diagnosis and they need these big surgeries and reconstructions. And we talk about getting them out of the hospital, being able to, not have wound care, but realistically, like how many of these people can go back to their normal lives and the normal sexual and urinary function, let alone do their jobs? I think if there is a way to catch these people in that prodromal state, like that's where the real impact is, I think.
Absolutely. It's a terrible disease to have in such a prolonged hospital stay. And you said, reconstruction and maybe lasting sexual and voiding symptoms and genital, cosmetic outcome is not great. When we look at the wounds coming together, it's usually awesome for us, but it's definitely life-changing for patients, not in a negative way. Dr. Barandra and I did a study where we called patients up after they had Fournier's gangrene, and we talked to them about their experience. And what was fascinating is that the patients were quite sick overall. They reported not leaving the house much, having diabetes, having trouble with mobility. And it was maybe that type of patient has it's them who have, when you see them in the prodromal stage, maybe there's these other markers that you can find that make them more prone of then developing Fournier's, because the patient we then interviewed after the fact had a lot of medical issues other than the Fournier's.
Yeah, that's one thing that, we talk about in-hospital mortality for them. And another thing that I would love to see is post-discharge mortality. We're spending so much time and effort to put these people back together and get them out of the hospital and kind of a livable quality of life. And I would love to see kind of what their long-term, outlook looks like. I think would be another kind of fascinating, look down the road.
Absolutely.
As soon as I wanted to talk about Fournier's, I knew that there was one person who would be doing this episode with me. So I really appreciate your time. Thank you so much for joining us on BackTable Urology.
Koch, it was a pleasure to talk to you anytime about Fournier's.
Anytime. And this won't be the last time.
Exactly.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.